The IsoBooth is a COVID-19, or was developed as a COVID-19 testing station with the intention that a care provider, a doctor, a nurse, a practitioner of any description could isolate themselves from a patient or a series of patients by entering the booth and using arm ports and attached gloves to be able to administer COVID-19 tests. Well, we learned about the Harvard-based product, and it really became a thought that it's important from a PPE provision perspective, that if we can economize or reduce the need for disposable PPE, that this would be a great way to do it. What we saw in the Harvard booth and the Massachusetts General Hospital booth, which are both sort of Harvard affiliates, Brigham and Women's Hospital, pardon me. South Korea used this type of booth extensively. And in fact, National Geographic around the 12th of May indicated that this type of booth was instrumental in the defense that South Korea launched against the COVID-19 infestation. So it was really, sort of a pivotal thing for them. So it just seemed, because it's an engineering control as opposed to a personal protective equipment personal control. It's more effective. It should give the care provider more confidence in their environment, and it should in fact reduce the consumption of disposable PPE significantly. It keeps both the patient and the provider safe in that there's a screen between the provider who may have contracted COVID, during their routine work. So there's a shield between, so, the droplet can't really exit from a properly protected healthcare worker, in theory, it should be difficult for it to be transmitted. But, there's a physical barrier between the patient and the provider that is, as I said before, an engineering control instead of a personal protective equipment. So it should give both the patient and the provider a greater, infection control measure. We have not actually. We've offered it to a number of hospitals on a trial basis. We've certainly entered into all the different government portals for offering. We, from a design point of view, we've been in touch with both Dr. Yu and Dr. Olson. Dr. Yu from Brigham and Women's Hospital in Boston, and Dr. Olson from Mass General, both Harvard affiliates and both have been very helpful in giving us, sort of their experience with what they needed to do to make their booths more effective. So all of the changes that we've made since we first implemented this. So we first started this project at the 1st April, when we sort of realized that it really could be a significant benefit. So within the first week, we had a prototype. Then we began, the process of trying to get it into the market and make people aware that we have it. In the meantime, we've had discussions with doctors in different jurisdictions in the province. So there's interest from a number of different healthcare authorities. But in the process of discussion with doctors, we then reached out to the folks at Harvard, the different versions, and they've given us advice as to the improvements that they've made over time. So we have, effectively, we have all of the features of successful high throughput booths that are in use in Harvard or in Boston and the surrounding area. New York State has some as well. It doesn't seem, there have been a number of sort of homemade versions. There was a fellow from the University of Waterloo, the engineering technology team that built one that was sent up to Perth Huron Medical. There's a company in Ottawa that made a booth that they took to Ottawa General. I don't think that actually was implemented, but there's recognition that there's a benefit. I think that the bigger challenge right now in Ontario and through the rest of Canada is that our testing, as you've probably seen in the news yourself, has sort of hit a hump in that our laboratory capacity hasn't been necessarily as full as it needs to be in order to provide the number of tests that everybody's wishing for. So, the premiers and the federal government had a meeting again last night regarding testing. The federal government's talking about offering every bit of support that they can, and obviously Ford and other provincial leaders are continuously talking about testing and wish to provide a greater amount of testing. I think there's been some difficulty with communication with respect to people actually participating. So you need patients in order to do the testing, and it hasn't been particularly clear that the testing is available uniformly. And so I think that some of the issue is messaging. Some of the issue is lab capacity, but the fact of the matter is, this past week we've had as few as, I think it was 6,000 tests approximately at the low point, and as many as 15,000 per day. We're targeting, or our lab capacity is currently 20,000 per day. Going back to the booth, though, the difficulty will change and increase as more elective surgeries are resumed, and a greater need in the hospital system is present for PPE. And as more of us get back to work, there's a huge demand in industry for PPE, and there isn't any. And so from a conservation point of view and from an availability point of view, the beauty of an engineered control like the IsoBooth is that it's fixed, and I don't need a gown. I don't need a new face shield. I don't need a new mask. I don't need goggles. I get in the IsoBooth, I do my testing. If we want to get into the fall and administer flu shots, I can do that from my IsoBooth, again, not with using any PPE. So as we expect the second wave is coming likely in the fall, or depending on how lifting of restrictions goes, it could be quicker than that. And the PPE is going to be needed, and there continues to be a shortage of PPE. So I think at this point, from our point of view, because we're regulated and administered by government, I think that from a use point of view, we really need to get more buy-in from the political side in order to be motivated, to reduce expenditure on PPE, and to take a view to the fact that if we can reduce the amount of biomedical waste that we're producing, that this type of solution can reduce the need for PPE. So it should reduce cost, and it should reduce reliance on something that we're disposing of. So the doctors are interested. The difficulty for the doctors is they have to modify their procedure a little bit. They need to involve their construction or their infection control people. And so, I think that medically there's interest. I had a great conversation with the healthcare center yesterday, that they're putting their budget together to implement an IsoBooth, and they love the idea. So it's in part for the doctors. They've been so busy, it's an awareness issue. So as we get more publicity that we have this environmentally sustainable and economically beneficial solution, as the awareness builds, then I think that if we can see the political will, then we'll have a little bit more traction with respect to freeing up some PPE for the elective surgeries and the other needs that we have in industry. So, and as I said, going forward, the beauty of this is it's made out of fiberglass polycarbonate and things that last for literally decades. And so, for flu seasons, for future needs of testing like this, there's dozens of applications for this in healthcare, and it's a one-time cost. So if the doctors were following full infection control procedures as recommended by Health Canada or CDC, they would be fully changing their PPE on a per test basis, which would mean that each test you would put on a new gown, you'd put on new gloves, you'd put on a new face mask, you'd put on new goggles, and you'd put on a clean face shield. Currently, for the most part, I'm understanding that's not being done, in particular in outdoor testing. But I've heard of a wide variety of stories, including And I won't even get into it actually, but there seems to be a lack of continuity from the infection control side. So the other benefit of the IsoBooth is that it would eliminate the discretion, or if we're struggling to find PPE, as I understand it, for example, the gowns are one of the biggest challenges, particularly disposable gowns. So if they're in short supply, as we've seen dozens of times in the news with nursing home providers, for example, they're just not changing their PPE. So if we have an engineered control that can be used by the health provider, then we benefit from that as a population, because now instead of having discretion of the doctor or the healthcare practitioner, or an intermediate measure from infection control because we have a shortage, now we have a full protective system that can be used every time reliably. So the patient's better protected, the doctor's better protected, or the nurse is better protected. We save money and we divert less plastic to the landfill. Yeah, that's a great point. The cost, I mean, on a one-off basis, you're in the $2,500 range per booth. If you compare that to the current cost of PPE on a per test basis, based on a study done in the 1st of April, because all of the prices have been inflated significantly by the COVID-19. So PPE is in short supply. Go to China, buy your PPE. Go to Malaysia, buy your gloves, and you're faced with cash at the door. The product goes to the highest bidder. So the successful government bidding that's happening with the larger, more established suppliers is still, at a more reasonable cost, although transportation and whatnot has gone up. But going back to what I started to say, there's an organization of healthcare procurement professionals that did a study. Their organization is called SHOP as an acronym, and they determined that on a per test basis, that the PPE for a COVID-19 test would be about $22. So if we look at that on a per test basis, a booth, typically one doctor or health practitioner is doing 100 tests per day. And so in one day, you're basically paying for the booth at current pricing. Now, having said that, they're not necessarily using all of the PPE or disposing of all the PPE, but at pre-COVID-19 pricing, the cost of the booth would still be recovered in about 10 days. So if they're using some, amount of PPE in between the proper amount and the actual amount, then they'll get a better infection control, and the cost will still be recovered, let's say easily under 30 days, but we'll have a more clinically safe situation. Now, industry, there's a number of large organizations that are intending to do testing on a daily basis or a weekly basis, so this type of thing. But if we're going into a plant like Toyota or some other, like a meat packing plant, what have you, you could have a person stationed in an IsoBooth doing a temperature check. So again, now I've got a provider that's able to operate without PPE, so more comfortable or safer regardless. We can do the screening with the 4 to 5 questions that are necessary to do a proper screen, that run through the health questions, do the temperature scan, admit the employee or in fact, in TNT supermarkets and some of the Longo stores, they've been doing the same for customers. So in the US, Target, Walmart, Amazon, testing employees as they enter the building, doing the screening. So again, you could use it in that circumstance, give better security and comfort. So, and you have to remember that the security and comfort is on both sides. So where you see the patient being, having a test administered, they're nervous. And so everybody's looking for comfort. 40 to 60% of us are wearing face masks everywhere we go. 80% are using them some of the time. So there is concern of the general public. So if they can see an engineered solution that appears to give them greater isolation from the healthcare provider who is exposed to it all day and might be able to transmit it to them, then there's greater confidence from the patient as well. So similarly in industry, both the person that's given the responsibility of taking the testing and the screening on a daily basis, and as well the employees that are encountering that person who's, coming in close proximity to all of the other people that were in line in front of them. So there's a greater benefit, again, from an infection control point of view by using a fixed barrier and one like we've got here. So we didn't start out to make this a real expensive product. I mean, really you could, as a short-term product, it could sell for a lot more, but we looked at it more from an environmental and contribution point of view. We've dedicated our homepage on our website at imaginefiberglass.com. That's fiberglass with an ER, not an RE. Some people spell fiber RE. So we have some information there. If you need more information, more technical information, because we have, again, with the help of, in particular, Dr. Chris Olson at Mass General, we've made some significant changes to, and we've added an option where you can do positive pressure. So now I can be fully enclosed in the booth with a slight positive pressure, meaning I don't have to wear anything. I don't have to wear a mask, no goggles, no single-use PPE if we do positive pressure. So a little bit more expensive option, but for a high volume testing application, so there's a little bit of interaction required with the facility and the infection control people at the facility that is seeking an ISO booth, because we need to understand how you want to use it and what sort of cycle you expect to have, like daily throughput, and then we can. So in that case, you want to contact us either by telephone or email. So you can telephone us at 519 area code 570-2841. And for additional information by email, you can contact us at sales@imaginefiberglass.com.